Hey, audience, you're going to have to pretend that Paul is here and really hating this pun that I'm about to tell. Why are tennis players bad at relationships? It's because love means nothing to them. Yeah, I really like that one.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cashback Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we are responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here for this intro without America's PCP, Dr. Paul Nelson Williams, but have no fear, he will be joining us for the interview here. This, of course, is part 2 of sports injuries with Dr. Carlin Center. On part 1, a couple weeks ago, we talked about concussion and femoral acetabular impingement. And on this part 2, we're going to talk more hip stuff. We're going to talk stress injuries. We're going to talk greater trochanteric pain syndrome. And we're going to talk some knee injuries too, like meniscus tear. So without further ado, let's get on to hearing about our guest, Dr. Carlin Center. Dr. Carlin Center is a primary care, sports medicine physician, and clinician educator at the University of California, San Francisco. She believes every patient is an athlete, and she enjoys helping her patients achieve their physical activity goals. She also loves learning about the musculoskeletal physical exam and teaching these skills to learners at all levels. She is fantastic, which is why we've invited her back. And we had such a great time recording this episode. A reminder that this and most episodes are available for CME for all health professionals through VCU Health at curbsiders.vcuhealth.org. And if you haven't done so yet, check out our Patreon at patreon.com/curbsiders, where you can get twice monthly bonus episodes, ad-free episodes, access to our Discord, the Cashlack Vault, a whole lot of cool stuff. Patreon.com/curbsiders.
Let's talk about Cameron. So Cameron is a 20-year-old woman, she, her pronoun. She's presenting with hip pain. She is a student and distance runner. So 3 weeks ago, she was training for a marathon, started really ramping up her weekly miles. So she went from 20 to 40 miles a week, which is a pretty good jump. And over the past week has developed anterior groin pain that has slowly gotten worse. She's starting to have a limp and she's not even able to run as much as she would like to anymore. So for this patient, who's a little bit different than our last patient, Sean, how does this history change how you think about this patient, or does it at all? And sort of how would you approach this patient?
This patient, I think, is great to contrast with the previous case. So in this case, this athlete is running more. The previous athlete, I think, was 10 to 15 miles a week. And that is something that I think is worth emphasizing when you're taking a history for a patient with hip pain, is if they're a runner, they might say, well, I don't run that much. But me running not very much, and then like one of these, pro runner people not running very much is very different. So, I might say, yeah, I'm not running much, and that's like, I'm running 5 miles a week. These people, they're not running much, and it's like 25 miles a week. Or I'm not walking much. Well, how much are you walking? Well, I'm walking like 6 miles a day. And you're like, oh, okay. So, quantify, just use objective measures for that. So anytime someone's running, I used to say 30, now I'm saying maybe 20 even miles per week, you're really getting into that's a lot of miles, and you're high risk for a running injury. And I start to get worried about hip stress fractures with these patients who are coming in with groin pain. It stopped her from running. That's a real red flag. There's not much that stops runners from running. So if a runner has stopped running and they're limping and they're coming in, that's a red flag for sure. And so all these things. So then I would start thinking about, well, what puts people at risk for stress fractures? And you can think about really what goes into having strong, healthy bones, and think about those factors. So you want to think about, has this person had a history of bone stress injuries? Because we know that if you've had a history of stress fracture, you're higher risk for repeat stress fracture. And then for women, you want to ask about their menstrual history, because the menstrual history can give you a sense of energy availability. Has this person had amenorrhea? If they've been running a lot and had an energy deficit, they may have amenorrhea. So ask about amenorrhea, ask about the onset of menses. So, was it 14, 15, or was it really like 17 years old, that would be a bit late and put this person at higher risk of lower bone density. Do they have any family history of low bone density? Do they use any medications that are known to cause osteoporosis? Do they have any food allergies? And asking people about food can be sensitive. And so to me, the question that I feel most comfortable asking people as kind of a starting point to introduce the topic, I just say, do you have any foods that you don't eat? Do you have any foods that you're not able to eat? And then that's kind of bridges to, have you ever really restricted the food that you eat? And then I'll also ask just broadly, like, especially if someone's gone through, an eating disorder, I'll ask, well, how is your relationship with food? Just broadly. And people tend to, I think, feel comfortable talking a little bit about that. And it's really, common for people, especially I think in their 20s, to have a complicated relationship with food. And running in particular, other sports as well, where you're kind of like battling, there are performance benefits to being lighter, and there's a lot about nutrition and sport. But if you overdo it, it's problematic. So taking a good nutrition history is helpful.
Yeah, and this red S, relative energy deficiency in sport, not something that I had really heard about, I guess. And so it's basically people that are just working out so much. I guess most people are taking in too many calories, right? And not burning enough. These people are the opposite problem. They're burning too many calories and not taking in enough. And you're sort of getting at there could be disordered eating that's going on here too. That's also another layer on the problem. And all this can affect bone health and predispose them to these hip stress fractures.
Exactly. Yeah. So this is the concept of female athlete triad. Male athlete triad was kind of what it was initially called, and it's evolved to now be called relative energy deficiency in sport. The main things, though, I think from a history standpoint to focus on are bone health, menstrual history, nutrition history.
Mm-hmm. Okay. Paul, you think you had a hip stress injury after hearing about this? Not the red stuff. I don't think you had reds, but your mileage was more than 20 miles a week at the time this happened, right?
I mean, it is now. Yeah. And I think I was marathon training. I had a pretty significant limp. I was not able to run. Yeah. So who knows? I did not get evaluated. It got better with time. But like, of all the things that we've talked about so far, this is the one that I did not try hopping. Yeah. So who knows? But this sounds hauntingly familiar to me.
Yeah. Now, it stopped you from running.
Yeah. Yeah.
Can this be seen? Like, if Paul had just an AP of the pelvis, like, might we have seen the hip stress injury or fracture, or does this often require MRI?
You can see this on X-ray if there's a fracture. So the bucket term for this would be bone stress injury. I'm concerned about a bone stress injury. And what does that mean? That means this could be a stress reaction, or it could be a stress fracture. And a stress reaction means there's no break in the cortex, so you will not see it on X-ray. You'll only see it on MRI. Stress fracture means the cortex is broken, and you will see it on X-ray.
Okay.
In a case like this, I would get an X-ray, and ideally, you put the patient on crutches, non-weight bearing, and get an urgent MRI.
So let's say we did get the X-ray in her, and it shows a fracture of the femoral neck. How are we counseling her? What we should do, and how's this going to be treated? What's the recovery like?
Femoral neck fractures can be really serious. When you see a femoral neck fracture on the X-ray, the first thing to decide is, does this person actually need to go to the emergency room for emergency surgery? And the way to decide that is, first, which part of the neck is involved. When you're looking at an AP pelvis, you look at the neck, and there's the compression side and the tension side. So when you're standing, you put tension on the lateral side, and you put compression on the medial side. So the tension side fractures need surgery. Same day, like they need to go to the emergency room. Because if they don't, what happens? They would get pinned, but if they don't, they would fracture all the way through, and they might need like a hip replacement. It can be devastating. So tension side needs emergency ortho, and compression side usually can be managed non-surgically. So that's good news. But the bad news is it takes weeks and weeks to heal. And you've really got to be careful with them. And they are in the category of high risk bone stress injuries. So it's really important to talk with the athlete and let them know, to set expectations appropriately. So typically we'll treat, to decide if you can treat this non-operatively, it depends on how bad the fracture is. Even a compression side fracture, if it's involving more than 50% of the femoral neck, might need surgery. To be safe, if you're diagnosing this, I would run it by ortho no matter what, basically. If you're seeing a femoral neck stress fracture on x-ray, to make sure that it does not need surgery, I'd make the patient non-weight bearing and run it by ortho. But vast majority of patients with compression side can be managed non-surgically. And generally, we do 2 weeks non-weight bearing on crutches. You can then advance weight bearing as tolerated and resume full weight bearing around 4 to 6 weeks, depending on when their pain resolves, as long as they have no pain. And then they can start stationary bike and pool running and aqua jogging as long as they don't have pain. The general return to sport after being injured rule is don't add more than 10% of your volume per week. That's again, that's totally not evidence-based, but it's what we all say.
It's a nice round number. Yeah.
Yeah. That just gives people a sense, I think, of exactly how slow you're meant to add stuff back. But it's a gradual program, and we really don't think about returning to running until 12 weeks have passed. If this is a bone stress injury and the x-ray has been normal, we'll sometimes repeat an MRI at week 12 to check and make sure it's healed. Sometimes people follow it clinically and an MRI, isn't done. There's no consensus on that. If this is actually a fracture that you've seen on x-ray, you should be doing x-rays along the way to double check that, it's stable and that it's healing.
Wow, this sounds serious. Paul, you probably had a reaction, not a full-on fracture, I would say.
Yeah. Well, here's hoping. I'd be the bigger picture. I should probably see my doctor, but we can talk about that offline.
Okay.
All right. So other than some of the counseling about sort of the gradual return to activity, I guess what other counseling or how do you explain sort of the patient's prognosis and what things to watch out for and sort of where to go from here after they're finally starting to recover from the injury?
The other things we would do as they're recovering is think about their bone health. So we would recommend a DEXA scan, and remembering that in premenopausal patients, we look at the Z-score, not the T-score. And also, the American College of Sports Medicine defines low bone density in female weight-bearing athletes as any Z-score less than -1. So that takes a little bit of just extra attention because that's different from the report that we get. Well, sometimes I forget what number it is, but it's more lenient than that. But if you're dealing with a female athlete who's in a weight-bearing sport like a runner, you'd expect them to have really great bone strength. And so the American College of Sports Medicine recommends we're a little stricter and hold them to a higher standard. So Z-score less than -1 is low bone density. And then doing sort of a secondary osteoporosis workup, as you would do for a patient where you're sort of surprised that they have low bone density would be appropriate. So some labs, counseling the patient about appropriate calcium and vitamin D intake, looking for, relative energy deficiency in sport, and then connecting the patient with folks who can help with that, whether it's a nutritionist, a registered dietitian, a psychologist. And then think about physical therapy who can help them optimize their mechanics with running and reduce their future injury.
Yeah, so a lot to think about. Paul, I don't think you need a DEXA, though. I don't know. Do you think Paul needs a DEXA, Carlin? What do we think?
I don't know. We'd have to dig into this a little bit more.
Okay. Talk about my tobacco history and how I deal with gluten. Well, again, I don't like to over-disclose on this show.
Exactly.
All right, Paul. Let's go on to the next case. We're still in hip land.
There's still more hip stuff. So we're going to talk about Drew now. Drew is a 50-year-old woman, she, her pronouns, with left hip pain. She has a past history significant for obesity and chronic low back pain. Drew works as a software engineer and states that walking, prolonged standing, climbing stairs, all these things increase the pain that she's been having. It's been ongoing for months now at this point. It even will wake her up in the middle of the night when she rolls over onto her left side, so she can't even sleep on that side anymore. When you ask her where the pain in her hip is, because we've listened to you and we're now being very specific, she points with one finger right to the lateral, the side of her hip. And when you palpate her left hip, she is tender over the greater trochanter, maximally at the posterior superior aspect of the greater trochanter specifically. So this theoretical clinician did a better exam than I did. So for this patient, we talked a little bit about this, but now we're in sort of lateral hip pain land. And I think My differential is pretty narrow for this, so I'd love to hear what you think about this patient and sort of what we should be worried about for Drew.
In this case, knowing the anatomy of the greater trochanter is really helpful, and palpating carefully. You can really palpate different structures as they insert on the greater trochanter. So if you think about the greater trochanter, let's picture the right hip, and let's picture the lateral side. So you're looking down at the greater trochanter of the right hip, and just think of it like a clock face. So 12 o'clock, 6 o'clock, 3 o'clock, 9 o'clock. So at the 9 o'clock position, the posterior superior aspect, that's where the gluteus medius tendon inserts. At the 12 o'clock position at the top of the greater trochanter, that's where the tensor fascia lata inserts, which is like the beginning of the IT band. It starts at your iliac crest and then moves distally and inserts at 12 o'clock at the greater trochanter. At 6 o'clock is where your IT band takes off and then travels down your lateral thigh to your lateral tibia. So knowing that, you can kind of press around and be like, oh, are you maximally tender at 6 o'clock? Oh, that's kind of more IT band. And then down your lateral thigh, that seems like an IT band problem. Are you maximally tender at 12 o'clock? Oh, that's TFL, tensor fascia lata. Or are you more tender at like 9 o'clock, in which case, 9 or 10 o'clock, I'd say, okay, that's more glute med. We used to call all glute medius problems, even all lateral hip pain, bursitis. And that's been disproven over time that all of this is bursitis, because now with MRI and things, ultrasound, it's been shown that actually the majority of these patients actually don't have bursitis. They have tendinopathy. So they have chronic dysfunction of their often gluteus medius tendon. And usually it's tendinopathy, which is basically chronic tendinitis. They can have partial thickness tears. Sometimes there can be coexisting bursitis. And then they also can have calcific tendinitis. So you can get calcium deposits in the tendon. Though I would say in Drew's case, if she had calcific tendinitis that were symptomatic, she'd be coming in with like really bad pain. I think her more kind of smoldering subacute symptoms seem more like tendinopathy.
Yeah, this is news to me. I think preparing for this, I thought someone had told me that it's not all just trochanteric bursitis, but I'm gonna have to put more thought into this. But the clock face thing that you gave us, that's I think I can follow that, Paul. I don't know about you.
Yeah, no, I think Ted Barks corrected us on the greater trochanteric pain syndrome, but I will say, if I can, Carlin, say glute med as coolly as you did it, just let it kind of just move past it like it's not a thing, I will have considered my career in medicine done. So I'm just impressed by that alone.
Is that really that's the pinnacle of your career, Paul, saying glute med in a cool way?
My career's not been great, man.
When we've made the diagnosis of this, what does it sound like when you talk to patients about, let's say they have glute med tendinitis or tendinopathy? Then what are you going to talk to them? How are you going to talk to them about that? And what can they do to get better?
The main treatment is physical therapy. And the reason we think physical therapy helps with tendinopathy, and this is tendinopathy of the hip, tendinopathy of the elbow, Achilles tendinopathy. Tendinopathy means that the tenocytes are all disorganized and they will actually regenerate. Like they'll grow back and be productive and non-painful, but they need the proper stimulus. And the reason these tendinopathies are so annoying is that the tendons don't have great blood supply. So unlike tearing, say you tear your calf muscle, it's going to swell a lot, it's going to be painful, but actually it's going to function pretty quickly. It's going to come back. That's because it has good blood supply. Same with your hamstring. But if you tear, say, your Achilles tendon, it is not going to heal itself because it does not have good blood supply. I should caveat, it can heal itself, but it takes a lot of time and special bracing. So different from a muscle tear, which is really well vascularized. So tendinopathy responds well to exercise, because what happens with specific exercise is you stress the tenocytes out, you bring in inflammation, you might get sore, but on purpose. You're bringing inflammation, increasing the ability for the tendon to actually heal. And that's been proven in chronic tennis elbow and is the basis for physical therapy for tennis elbow. It's why most people have stopped putting cortisone in folks with lateral epicondylopathy, because it doesn't make sense really to put steroid in an area that needs inflammation. the purpose of steroid is to be an anti-inflammatory. So typically we'll recommend physical therapy and activity modification, trying to not overload that tendon, but to follow a physical therapy program. And the other thing to know about glute tendinopathy is it often coexists with low back problems. And so, these patients, if say if Drew also had some low back pain, you'd want to include that in the physical therapy referral as well.
I guess, are we shying away from NSAIDs and ice as well if we're thinking that inflammation can be good for injuries? Now, Kelly Starrett, I heard him talking about that, and I wasn't sure if he was, just going rogue, as I imagine he tends to do sometime, or if that's like a real thing now people are moving towards or away from.
It's a hot topic in the world of sports medicine. I think it's not clear.
Okay.
It's not clear. Say you have an acute ankle sprain. Should you use ibuprofen, or is that actually decreasing your ability to heal, from the ankle sprain? I think we don't know.
Okay.
It's an interesting lever because, with any kind of physical therapy, you always have to sort of anticipatorily be like, it's going to get worse before it gets better. So if you have a mechanistic reason why that's actually a good thing, like that's actually, it's fascinating. This is not a way that I thought about this before, but if you can explain, like the inflammation is actually helping you, and it's okay if you suffer in the short term because that's going to allow for healing in the long term. I'm not sure if that will convince more people to go to physical therapy or not, but it's an interesting framework.
I mean, I think it's similar to strength training. Think about when we strength train, when you try to build strength or increase muscle hypertrophy, you are, you're often uncomfortable. So you need to overload the tissue, and then you need to rest the tissue so that it can heal and get stronger. And then you need to overload it again. And that's the purpose of physical therapy for these tendinopathies.
I don't typically order imaging for patients if I think they have greater trochanteric pain syndrome, but is this something that you're getting if in certain cases, maybe they're not responding to physical therapy? How do you approach that?
I agree. I think if you're seeing a patient who comes in, say, with a 2-3 week history of lateral hip pain, I would hold off on doing hip x-rays at that first visit. I would, unless you thought they had calcific tendonitis or, really bad pain. But in cases where, they're walking, they don't have a huge limp, there's been no trauma, I think totally reasonable to hold off and see if physical therapy will help. If the patient's not getting better, I would go ahead and get radiographs. And most of the time in greater trochanteric pain, you're going to have a normal radiograph, and then I would proceed with an MRI.
Before someone's getting in with PT, I know UCSF has a lot of great handouts for certain things. I don't know that I've looked up if you have handouts for this, but what exercise might we tell them that they can do just while they're waiting to get in with physical therapy?
Yeah, thank you for highlighting our rehab resources. Our athletic trainers have put together like a phenomenal website with short video clips and PDFs of rehab protocols. So if folks are looking for a resource to share with patients or family members who are injured, it's out there for you. But the types of exercises are really like hip flexibility and hip strengthening. So generally speaking, before exercising, you want to do a short dynamic work, sort of warm up. So if you've been, sitting all day or you've just woken up from sleeping, you want to warm the body up. And that might be jumping around or just moving the body similar to the ways that you're going to do strength training, but with no weight. And then you would go ahead and do some strength. And in this case, things like clamshells, which is when you're lying on your side and bringing the bent leg up and down. So it's basically like repetitive hip abduction. The gluteus medius is a hip abductor and brings your leg out from midline. So any exercise where you're bringing your leg out from midline is going to exercise your glute. But I would say it's not always easy to activate one's glute. And that's why a physical therapist or a personal trainer can be extremely helpful in these cases, is to make sure that you're not, recruiting other muscles, but you're actually recruiting the glute.
Okay, great. Yeah. And those handouts, I print them out often and give them to patients for various things. There's great handouts for back pain and knee, shoulder, all those things. So Paul, do we have anything else to talk about on this topic? Have we cured our patient here, or what do you think?
Yeah, sure. I think we'll give. Why don't we say we recommend physical therapy, and they're doing great and sleeping well now.
All right. I think we should end by talking about the knee, Paul. So can you give us a case?
Great. So we're going to talk about Kai. Kai is an 18-year-old woman. Pronouns are she and her. She's coming in for 1 week of left medial knee pain that happened after she made a sudden turn while playing for her college soccer. Matt, that's European football or the football, I think they call it. Are you
Yes,
familiar?
I'm
Okay,
very
cool.
familiar.
All right, so I think they kick a ball around. I'm not sure. I don't really follow sports much. But in any case, Kai, I guess, made a sudden turn. Her left knee hurts. She's having some medial pain. She developed swelling later that evening after the injury actually initially occurred. Having some pain there, but is not reporting any knee locking or any knee instability. So not giving out, not locking up on her, but she does have swelling and pain of the knee. So for Kai here, who's playing soccer, Matthew?
So we can call it soccer, I guess, since most of our audience is in the U.S.
Okay, great. So this patient hurt themselves playing soccer with a twisting injury. What kind of things do you think about, and sort of where do we go from here for her?
I like that you presented kind of 3 key things in her history. 1 is, does she have swelling? 2 is, does she have any knee locking? And 3 is, does she have any knee instability? So those are 3 things that I think are really important for any person with an acute knee injury. Swelling, I'm wondering if they have an effusion. I don't think patients actually are that good at telling us whether or not they have an effusion, frankly, but it's good to know if they feel their knee is swollen. And you can decide if it's an effusion or not. Locking. So what am I looking for there? So if a patient says, yeah, my knee is locking, I'll say, well, tell me about the last time it locked up. Tell me exactly what happened. And what I'm looking for is, did the knee get stuck and you couldn't move it? Like literally you felt like there was something in your knee. Most people will say, oh, that's not what I meant. They'll say, no, what happens is my knee clicks when I get up from sitting. And I'll say, oh, it's like catching. They're like, yes, it's catching. It's not locking. So catching, locking. But just ask the patient, yes, my knee's locking. Well, tell me about that. And then knee instability. So if your patient says, yeah, my knee's unstable, I'll say, well, tell me, like, when was the last time it was unstable? So what I'm looking for is, when I walk around the corner, my knee pivots or twists in a weird way. And that would be indicative of like an ACL tear. Most of the time when people have knee instability, it's because they have pain. And it can happen all the time with kneecap problems, whether it's patellofemoral pain syndrome or patellofemoral arthritis. I'm walking downstairs, my knee hurts and it feels unstable. It feels like it's going to give out. So I'm not worried. That's not a red flag. That's good information, but I'm not worried you've torn your ligament if that's what's happening, because that's instability in sort of the anterior posterior plane. I'm looking for torsional instability.
The other anterior posterior one, people, they say my knee feels like it's going to give out when I'm walking. Like,
yeah.
Is that another one that's not as much of a red flag as the twisting?
Yeah, exactly. Yeah, I'm really looking for, like, do you feel like your knee like translates in a weird way? And I'll sort of demonstrate, say, the femur coming apart from the tibia. That's what we're looking for. In her case, though, she says, yeah, she has some swelling, and also the timing. So when you ask about swelling, okay, your knee swelled up. When did it swell? People who tear their ACL, the ACL has an artery, and so it will swell right away. It's a hemarthrosis, it's bloody. Same with fractures, same with patellar dislocations. They have large effusions and they're immediate. Meniscus tears, they swell, but they swell later. So you'll get an effusion that evening, certainly by the next morning. So in this case, you're getting a hint like, okay, she got some swelling. It happened kind of after the injury and it's medial. And so I would use the same framework that we talked about with the hip. So you do history, then you're going to inspect, you're going to palpate, you're going to do range of motion, and then you're going to do other tests. So that framework is called HIPROT: history, inspection, palpation, range of motion, other tests. You always want to expose the joint. So ideally, your patient is in a gown or shorts, and then ask the patient to walk and inspect their gait. Do they have a big limp? Do they have a lot of quad atrophy? Quad atrophy would indicate this is like an old injury, And then palpation. So I'm going to highlight here, I guess we won't talk about the whole knee exam, but really I think highlighting in this case, what I would do for this patient with this traumatic injury. And I'm thinking she has a meniscus tear just based on her history, but you should also check her ligaments. So first we're going to palpate her joint lines, and I would do that with her seated, with her feet ideally off the ground. And what that does is it allows gravity to pull down on the tibia, and you can really palpate the joint line. So putting your thumb firmly between the femur and the tibia. You'll feel kind of like a soft, squishy gutter. And you want to palpate the lateral, then the medial, or the medial, then the lateral, but one at a time. Sometimes I see folks kind of try to put their thumbs on either side of the joint line and palpate sequentially both medial and lateral at the same time. And I think that's very difficult for us to like perceive. Like the patient's getting a lot of input there and may not give you as much information if you palpate one at a time. So palpate carefully the joint line. You can palpate the medial knee, palpate the MCL, which is on the medial femoral condyle, and then extends down to the medial tibial plateau. And then I would have the patient lie down. I would check her range of motion, looking for, can she fully extend? Can she fully flex? And how does that compare to the other side? In this patient's case, because she does not have a locked knee, she might be able to get to full extension. But in a patient whose knee is locked, they won't be able to fully extend. And a patient with a locked knee, you'd be worried about a meniscus tear, but a type of meniscus tear called a bucket handle meniscus, where the meniscus tears and it flips up like the handle of a bucket into the joint, and the joint is stuck. And that's a surgical urgency, because if you walk on a bucket handle meniscus tear, it'll get chewed up and very difficult to repair. But if you catch it early, it can be sewed back and the meniscus is functional again. In her case, though, she probably has an effusion, but she probably has pretty good range of motion. And then you want to go ahead and do some meniscus testing, specifically the medial and lateral McMurray, and then the ligament testing while she's in a supine position. One important thing about all these exams is helping your patient be relaxed. And so I generally will examine the unaffected side first. And that helps them understand kind of what you're going to do on the affected side. And then go ahead and test the ligaments, test the meniscus with the McMurray. I think the McMurray test can be challenging because there's kind of a lot going on when you do a McMurray. So I'll describe it, and then I would encourage folks to look up some videos about how it's done. I'll plug our UCSF Ortho YouTube channel. We do have some pretty good physical exam teaching videos there. And so if you just put that in and sort of search for knee, you'll see some of our amazing clinician educators teaching their physical exam pearls. To perform a McMurray, to look for a meniscus tear, you want the patient supine. You're going to hold their foot with one hand and their knee with your other hand, and you're going to flex the knee. So you're going to bring their foot in towards their hip and really bend the knee bend the knee as much as you can. And then you're going to turn let's say you're testing the medial meniscus, you're going to turn the toes out and give a few rotations, and then bring the knee into full extension. Your one hand is holding the foot, your other hand is holding the knee, and that hand is technically trying to feel to see if there's a pop, because classically the McMurray is positive when there's a pop at the joint line. But I will say that's almost never happens. If you're feeling a pop, it's probably patellofemoral crepitus. And so really the thing is just look for pain. And so people with an acute meniscus tear, they'll feel it, they'll be uncomfortable. They might even jump if they have a medial meniscus and you do a medial McMurray. To do a lateral McMurray, you do the same thing. So you're holding, say it's the right knee. I would put my left hand at the patient's joint line on their knee. I would put my right hand under their foot. I would bend the knee so that it's deeply flexed. And to test the lateral meniscus, you would turn the foot in and you give a few rotations and then extend the joint and look for pain laterally. So that's McMurray. And then you would go ahead and test the ligaments, the ACL, MCL, LCL, and PCL. In this case, we can presume those are fine. And then two more meniscus tests to talk about. One is Thessaly, which is my actual very favorite test in all of sports medicine.
I'm so happy to hear you say that. I love the Thessaly test. I've heard it poo-pooed, so I'm glad to have a fellow Thessaly supporter.
I love
Sorry, I didn't
Thessaly
interrupt.
test.
I'm just very excited now.
Yes. This is also a test that isn't for all of my patients. So, use this test wisely, but it's really fun to do, which is why I like it, because you kind of get to dance with your patient. So you ask the patient to stand. I would do it on the unaffected side first. And you can do this as you're listening if you like. So you would stand on one leg and hold on to something for balance, or hold on to your doctor, and bend your knee a little bit, and then pivot your torso on your knee. And so you're going to move side to side, medially and laterally, have them do 3 times. And the idea, what you're doing is you're providing an axial load because you're standing on your knee, and then you're twisting. And so if you twist medially and the patient gets medial pain, it's a positive thessaly for a medial meniscus tear. And the opposite is true for lateral. That's thessaly. And I think it's fun just because you get to see how people move and they hold on to you and you kind of do this dance. And it's kind of fun. And the last one is squat. And the squat test has been tested in primary care settings. A lot of these maneuvers are all tested in orthopedic clinics. And I think that makes it a little bit challenging to know the sensitivity and specificity of these maneuvers when you're in primary care because they were never tested in primary care. But the squat test has been, and it's quite sensitive and specific for meniscus tears in a primary care setting. So for squat, again, not for all of our patients, but for your patients who are able to squat, you would ask them to hold on to you for balance and to squat. And if they have medial pain or lateral pain with a squat, that's another meniscus finding. Patients will sometimes have patellofemoral pain with squatting, and that's good information, but would not be concerning for meniscus tear. So ask them if the squat hurts, ask where does that hurt?
Yeah. So if it's anterior knee pain, that's like more the patellofemoral pain than the meniscus.
Exactly.
Mm. All right. So let's get some more history in this case, or give some more of this case.
Sure. In Kai's case, she has, as you predicted, a moderate effusion. She has full range of motion, but she does have pain with full extension and flexion. She does have some medial joint line tenderness and a sharp medial pain with the medial McMurray test. She also has difficulty getting to a deep squat because of this knee pain. We decided to be nice and not dance with her for the thessaly test as much as we would like to, because we already feel fairly good about the diagnosis. So it sounds like this is confirming our diagnosis of a medial meniscal tear. So from here, I guess, is there any other workup necessary? Do all these folks earn imaging? What kind of additional workup do we do for this patient?
Yes, this patient, I would order radiographs. Most likely those will be normal in Kai's case, and then an MRI.
Yeah, I'm used to not ordering MRIs for patients. Kai is 18 years old, so it is still playing sports. Is that why? Like if Kai was 48 years old and would you still do the same thing here?
Yeah, it's a good question. When I think about ordering an MRI, I'm thinking about a few things. One is the patient's age, because the younger the patient, the less likely they're going to have any arthritis. And we know that the benefit of arthroscopy for meniscus surgery goes down the more arthritis is in the knee. And that's why to get radiographs is that, if you see arthritis on a radiograph, then you would think twice about getting an MRI. But in an 18-year-old, it would be pretty unlikely that she would have any knee arthritis. I think the other things that go into the decision-making about getting an MRI and how urgently to get the MRI are what is the patient doing and how functionally limited are they? So if Kai is a professional soccer player, she's going to need to have the MRI really soon and have this figured out because this is taking her out of her job. And similarly, if this is someone who's got a job where they rely on their knee for whatever physical activity they have to do, I would urgently, you would expedite the workup just because they're going to have to miss work until this thing gets fixed. The other red flags, that I'm looking for, we talked about a locked knee. In a patient who's a bit older, you would want to think about a meniscal root tear.
Yeah, I hadn't heard of that before. If you want to just explain why that's different than we talked about a bucket handle tear, and there's radial tears, horizontal, there's all sorts of tears, but what's so special about the root tear?
A root tear, so the meniscus, when you think about the anatomy of the meniscus, if you picture looking down at the tibia and remember that there's a medial meniscus and a lateral meniscus. And the meniscus it's thick fibrocartilaginous tissue. So it's like a bumper between your bones and they're C-shaped really. So the anterior and posterior ends of the meniscus have roots. They're for each meniscus, there's an anterior root and a posterior root. And really, it's the posterior roots that can get injured, particularly in like a young soccer player. If she had an ACL tear, she also could tear the posterior horn of the posterior root of the lateral meniscus. That's not a common injury, but it can happen. A patient who's older than Kai, say a middle-aged patient, could tear the medial meniscus posterior root by doing something like relatively benign, like stepping off a curb. I felt a pop. My knee got super, super swollen. That's a case, and I'm 50 years old, that's a case where I would think about a medial meniscus root tear. So and the reason that root tears are so important is when you tear your root, you actually destabilize the entire meniscus. So you no longer have the shock absorbing capacity in your knee. And if it's not treated, if you don't have the root tear fixed, you're at much higher risk of knee arthritis. It's like having a total meniscectomy.
Yeah. So I guess for the older patient, are they going to have more swelling or locking, or just they're just not going to be functioning as well, and that might push us to get the MRI to find this? Because a lot of the times, if it's someone you think has a lot of arthritis, you're less likely to get an MRI.
Yeah. Let's say we have a middle-aged patient who comes in with, sort of a less acute situation. Let's say she's 50 years old and a month ago she stepped off a curb, felt a pop, and her knee became swollen and it remains very swollen. I think the large effusion is really important. Patients may have knee arthritis, but if you have a patient who has knee arthritis and something happened and now their knee is super swollen and they haven't previously had swelling, it's something to think about. Now, of course, you can have a flare of knee arthritis, and that's how it presents as well. So I think it's hard. We don't have a great way, I think, of differentiating on exam, which of these middle-aged people need an MRI. And certainly in primary care, where we're seeing a lot of people who come in with kind of subacute, somewhat benign knee injuries with knee swelling, I think it's really challenging. But I would look out. Root tears are more common in women than men. They're typically women, middle-aged women. And again, knee was doing fine, did something relatively little, and now knee is quite painful, very swollen and painful in the back.
So for our patient, we get an MRI. What else are you telling them to do in the meantime while we're waiting for the MRI results if we're pretty sure this is a meniscus injury?
Yeah, in Kai's case, this 18-year-old with the meniscus tear, she doesn't really have red flags on exam. Like her range of motion looks good, her effusion's not huge. So I would just have her, do some rest, ice, compression, elevation, standard stuff, and go ahead and get the MRI.
Okay. And then we'll find out eventually if we're supposed to stop doing this ice and NSAIDs and those things.
Prior
conversation.
different situation. Yeah, would her meniscus tear heal better if she didn't rest, ice, compress, and elevate it?
Yeah. Okay. So actually, we had written another case, but I think we answered most of the questions. But I guess just to sort of end this topic of meniscus tear, which has always been a little confusing to me because you see all those studies saying a lot of people don't benefit from surgery. Can you just sort of boil it down, like who are you sending to surgery that's like more likely to benefit, and who probably doesn't need surgery?
Yes. I think the case of the young soccer player is illustrative of an acute meniscus tear, and those patients clearly benefit from surgery. And the studies that have shown a lack of benefit from meniscus surgery, those are studies on patients who have degenerative meniscus tears. And so the history for those patients will be one where their knee is hurting, but there's not been an injury. And on physical exam, you would find that they would have meniscus physical exam findings, like we talked about with the first case, joint line tenderness, McMurray, Thessaly, squat. But they also would have arthritis exam findings, so they would be tender on their bones, the way that arthritis patients are. And when you have a patient where they have concomitant exam findings, bony tenderness with meniscus findings, and it's a subacute chronic situation, no acute injury, I would think of those patients, okay, this is probably a patient who has, in their middle age or elderly. I would say this patient probably has arthritis or a meniscus tear, arthritis and a meniscus tear. And randomized controlled trials would say that these patients do just as well with physical therapy as they do with arthroscopic surgery. So these patients don't need an MRI, and what they should do is sort of your standard non-surgical knee osteoarthritis treatment program. And also from those studies, it's important to know that about 30% of patients who were randomized to physical therapy actually crossed over to arthroscopic surgery. So these patients actually didn't get better with physical therapy, and they were allowed in these studies to cross over. And this has happened in like 3 or 4 of these RCTs. So always just keep an open mind with your patients and ask them to see you along the way with physical therapy, because a certain subset of them won't be getting better. And I would refer those patients over to sports medicine to see if they actually need arthroscopy.
Yeah, that's a great point. The crossover thing. I hadn't really heard about that before, but that, because you do still see a fair number of patients telling you that they got arthroscopy, and some people are happy with the results of it. So
yes,
it's good to know that there's evidence to support that.
Mm-hmm.
It's not just like nobody is going to benefit from it in
Mm-hmm.
that situation. Well, Paul, I don't know. I mean, we could go on forever, but I think we should probably let Carlin go. What do you think?
This might be a record for us, which I think we should be very proud of. But yeah, no, I think we did yeoman's work today, man.
All right, Carlin. And how about some take-home points on hip and knee?
So for hip, I think we talked about the red flag, which is a femoral neck stress fracture. And so remembering when you're interviewing those patients to really take a detailed history about mileage they're running per week, and then get into the weeds a bit about their bone health, their nutrition history, their menstrual history. And all of those things can increase or decrease your concern that this may be a femoral neck stress injury. We talked about the different kinds of impingement, CAM and pincer, and that physical therapy is the first treatment of choice for patients with hip impingement. And we talked about greater trochanteric pain syndrome. The majority of the patients have gluteus tendinopathy. Turns out it's not bursitis, and they benefit from physical therapy. With the knee, we talked about meniscus tears, and in particular, recognizing that acute meniscus tears, when patients don't have osteoarthritis, benefit from surgery. In contrast, patients who have subacute to chronic knee pain, where your physical exam shows that they probably have both knee arthritis and a meniscus tear, those patients benefit from your standard knee osteoarthritis non-surgical treatment protocol. But once in a while, those patients won't improve with that treatment. And to think about, should those patients get an MRI, perhaps they should see a sports medicine specialist.
And before we end officially, anything that you would like to plug?
Thank you. I would love to plug our group at UCSF Sports Medicine and our group of clinician educators. We do a lot of teaching. We love teaching, and would invite anyone who is a sports medicine fan to come out and join us in December. Every December, we have a conference in San Francisco. It's a great time to visit the city, and we do a ton of sports medicine teaching. Even opportunity to do hands-on physical exam coached by all the clinicians in our practice, and we have a great time. So join us this December 5 to 7 and December 5 to December 7. And then the other two tools I'd love to share with folks, I think I mentioned the UCSF Ortho YouTube channel. And if you go there, there's tons of videos from many of our past courses. You can just search for knee or shoulder or any topic really and find some pretty great physical exam videos and other like injection how-to videos, things like that. And thirdly, for your patients and any injured family and friends, we have a video. If you Google UCSF Sports Rehab, you'll find our rehab website. And we have short videos put together by our athletic trainers and accompanying PDFs with rehab protocols. So if you have a patient who can't get to physical therapy, or maybe there isn't physical therapy close by, you can provide them with a rotator cuff rehab protocol from that site.
So fantastic. Thank you so much for coming back on the show.
You're welcome. Thanks, everybody.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Still hungry for more? Join our Patreon and get all of our episodes ad-free, plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find our show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. This includes the Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge. And to do that, we need your feedback. So please send us an email at askcurbsiders@gmail.com. I also wanted to give a special thanks to our writers and producers for this episode, Dr. Edison Jang and Dr. Pete Wyckoff. And to our whole Curbsiders team, our technical production is done by Podpaste. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Krista Chu Manchu moderates our Discord. Stuart Brigham composed our theme music. And with all that, Paul, until next time, I've been Dr. Matthew Frank Watto.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.